Distributive shock in neonates is defined by inappropriate vasodilation and maldistribution of blood flow, leading to impaired tissue perfusion despite normal or even elevated cardiac output in the early phase. The key physiologic abnormality is a fall in systemic vascular resistance, which lowers perfusion pressure and limits oxygen delivery to vital organs. Unlike hypovolemic shock, where preload is inadequate, or cardiogenic shock, where pump failure dominates, the problem here is that blood flow cannot be effectively directed to critical tissues. Septic shock is by far the most common distributive process in the NICU. Neonates mount an exaggerated inflammatory response to infection, releasing cytokines and nitric oxide that drive vasodilation, increased vascular permeability, and myocardial depression over time. The fragile neonatal capillary network and immature innate immunity make preterm infants particularly susceptible. Anaphylaxis is less frequent but clinically significant, typically triggered by blood product transfusion, antibiotic exposure, or maternal medication transfer. Histamine and other mediators cause systemic vasodilation, capillary leak, and often respiratory compromise due to bronchospasm. Neurogenic shock, though rare in this population, may occur with birth-related cervical spinal cord injury. Loss of sympathetic tone below the lesion produces profound hypotension and bradycardia, distinct from the tachycardia that usually accompanies other forms of shock. Drug-induced distributive states can be seen in neonates exposed to opioids, high-dose anesthetics, or magnesium sulfate, all of which blunt vascular tone and autonomic responses. Another important contributor in critically ill infants is adrenal insufficiency, either due to congenital adrenal hyperplasia or acquired relative adrenal insufficiency in sepsis, which removes cortisol's permissive effect on vascular tone and amplifies shock physiology. At the bedside, distributive shock should be suspected when an infant remains hypotensive with warm extremities, bounding or variable pulses, wide pulse pressure, and poor end organ perfusion despite adequate intravascular volume. Recognition is vital because management differs from purely volume-responsive states. Therapy emphasizes vasopressors such as dopamine, norepinephrine, or epinephrine, coupled with targeted treatment of the underlying trigger. Antibiotics for sepsis, epinephrine for anaphylaxis, corticosteroids for adrenal insufficiency. Excessive fluid resuscitation can worsen pulmonary edema and compromise oxygenation, particularly in preterm infants with fragile lungs. The unifying concept is that despite apparently sufficient cardiac output, perfusion fails at the tissue level. Timely recognition and early escalation to vasoactive support are essential to prevent progression to multi-organ dysfunction in the neonatal population. Septic shock is the most important and most frequent subtype of distributive shock in neonates and children. It begins as a systemic inflammatory response to infection, with release of cytokines and mediators that disrupt vascular tone and endothelial integrity. The result is widespread vasodilation, which lowers systemic vascular resistance and creates a distributive shock state. Capillary leak compounds the problem by shifting plasma volume into the interstitial space, adding a hypovolemic component. At the same time, inflammatory mediators and circulating toxins can directly depress myocardial contractility, producing a cardiogenic element. The combined effect is reduced effective circulating volume, impaired forward flow, and maldistribution of perfusion. Sepsis also triggers activation of the coagulation cascade, leading to microvascular thrombosis, consumption of clotting factors, and in severe cases, disseminated intravascular coagulation. As these processes evolve, multiple organs become dysfunctional due to both inadequate perfusion and direct cellular injury. This multifactorial pathophysiology explains why septic shock is complex to manage and why it carries such high morbidity and mortality in the neonatal and pediatric population. In the warm phase of septic shock, inappropriate vasodilation lowers systemic vascular resistance. The vascular bed opens widely, causing blood to pool peripherally rather than being directed to vital organs. This produces flushed skin, bounding pulses, wide pulse pressure, and brisk capillary refill, all signs that flow is maldistributed, not deficient. As compensation fails, cold shock develops. The neonatal heart has limited ability to increase stroke volume, so cardiac output falls rapidly. Vasoconstriction becomes the dominant response in an attempt to preserve central perfusion. Clinically, this results in cool extremities, narrowed pulse pressure, weak or thready pulses, and delayed capillary refill. Temperature instability is one of the earliest systemic signs. Neonates rarely mount a fever. Hypothermia is more common because the immature immune system does not generate a strong pyrogenic response, and limited thermoregulatory capacity makes even small losses critical. Neurologic changes are subtle but significant. Poor feeding, lethargy, irritability, or hypotonia occur because the brain receives inadequate oxygen delivery, and metabolic derangements impair neuronal function. Perfusion abnormalities, such as mottling and discrepancies between central and peripheral circulation, reflect uneven blood flow and early tissue hypoxia. Renal hypoperfusion leads to oliguria. Unlike the physiologic low urine output of the first 24 hours, persistent decline in urine output indicates sustained inadequate renal blood flow and is often an early marker of systemic compromise. Finally, metabolic acidosis and rising lactate represent the biochemical signature of impaired oxygen delivery. Cells shift to anaerobic metabolism, producing lactic acid, and this laboratory finding often precedes hypotension, which is a late and ominous sign in neonates. Management of septic shock in neonates and children depends on early recognition and rapid intervention. Progression to cardiovascular collapse is common if treatment is delayed. The first priority is aggressive fluid resuscitation. Isotonic crystalloid boluses of 20 milliliters per kilogram are given, and cumulative volumes may exceed 60 milliliters per kilogram depending on response. Careful titration is necessary to avoid fluid overload. Antibiotics should be administered within the first hour, since delays increase mortality. If fluids alone are inadequate, vasoactive support is indicated. Dopamine is often used as an initial agent in pediatrics. Epinephrine is recommended when shock persists despite dopamine, and norepinephrine is most effective in warm shock characterized by severe vasodilation and low systemic resistance. Corticosteroids may be added in catecholamine-resistant shock, particularly when adrenal insufficiency is suspected. Source control is equally important. Drainage of abscesses, removal of infected catheters, or surgical procedures to eliminate the nidus of infection must accompany hemodynamic management. Throughout care, close monitoring of vital signs, urine output, mental status, and laboratory indicators of acidosis guides therapy and helps prevent multi-organ failure. Assessment of shock at the bedside depends on systematic evaluation of multiple parameters rather than any single vital sign. Vital signs provide the foundation. Blood pressure should be measured in all four extremities, as discrepancies may reveal obstructive lesions, such as coarctation or interrupted aortic arch. Heart rate and respiratory rate must be interpreted in the context of perfusion. Perfusion assessment is crucial. Capillary refill time reflects microcirculatory flow, while skin temperature and color indicate the degree of peripheral vasoconstriction. A cool, pale, or mottled appearance is a sensitive sign of early compromise. Pulse quality gives further insight into hemodynamics. Weak, thready pulses are consistent with low stroke volume or poor output, while bounding pulses may suggest a pathologic runoff lesion, such as patent ductus arteriosus. Neurologic status must also be monitored. Irritability, lethargy, or reduced responsiveness signal impaired cerebral perfusion and are often earlier indicators than hypotension. Urine output is an essential end organ marker. The goal is greater than 1 milliliter per kilogram per hour, as reduced output reliably reflects falling renal blood flow. Together, these physical findings provide a more sensitive and earlier diagnosis of shock than blood pressure alone. Laboratory studies complement the physical exam by identifying metabolic changes and uncovering underlying causes of shock. Blood gas analysis is one of the most informative tools. Low pH, elevated lactate, and a rising base deficit indicate tissue hypoxia and anaerobic metabolism. These findings reflect the adequacy of resuscitation and help guide therapy. A complete blood count provides several critical insights. Hemoglobin concentration identifies anemia as a contributor to poor oxygen delivery. White cell count may suggest infection or inflammation, and platelet levels provide early warning of consumptive coagulopathy. The comprehensive metabolic panel evaluates electrolytes and renal function. Abnormal sodium or potassium levels may worsen arrhythmias or contractility problems, while rising creatinine or blood urea nitrogen indicates reduced renal perfusion. Liver function tests add another dimension, as elevated transaminases can reflect hepatic hypoperfusion or shock liver. Coagulation studies assess for disseminated intravascular coagulation, a common complication of sepsis and severe shock states. When infection is suspected, blood cultures are essential. Identifying the causative organism allows targeted antimicrobial therapy, which is critical for reversing septic shock. Laboratory data, when interpreted alongside clinical findings, not only confirm the presence of shock, but also highlight contributing factors and guide both immediate and definitive management. Advanced hemodynamic monitoring provides detailed insight into the cardiovascular status of neonates and children in shock, guiding precise interventions beyond what physical exam alone can reveal. Central venous pressure reflects ventricular preload. Elevated or low values help distinguish between volume overload and depletion, informing fluid resuscitation decisions. Arterial lines enable continuous beat-to-beat blood pressure monitoring, which is essential for early detection of hypotension and evaluation of response to therapy. Pulse contour analysis offers dynamic information on stroke volume variation, indicating whether cardiac output is likely to improve with additional fluids or requires inotropic support. Echocardiography allows direct assessment of cardiac function, including ventricular contractility, chamber filling, and valvular competence, providing real-time guidance for tailored management. Mixed venous oxygen saturation measures the balance between oxygen delivery and consumption. Low values signal inadequate tissue oxygenation despite apparently normal systemic blood pressure, emphasizing the need for optimization of cardiac output and oxygen delivery. Integration of these modalities enhances the clinician's ability to detect early decompensation, distinguish shock subtypes, and titrate therapy appropriately, ultimately improving outcomes in critically ill neonates. Hemodynamic management in neonatal and pediatric shock is guided by clear, measurable goals that indicate adequate tissue perfusion and oxygen delivery. Maintaining age-appropriate blood pressure is essential to ensure sufficient perfusion of vital organs, but blood pressure alone is not a reliable early marker of shock in children. Clinical assessment of perfusion is equally important. Warm extremities and brisk capillary refill reflect effective microcirculatory flow, while normal mental status indicates adequate cerebral perfusion. Renal output serves as a sensitive end organ marker. A urine output greater than 1 milliliter per kilogram per hour demonstrates that kidney perfusion is preserved. Metabolic markers provide additional confirmation. Normalization of lactate and base deficit indicates that oxygen delivery meets tissue metabolic demands, and that anaerobic metabolism has been corrected. Achieving these hemodynamic targets requires ongoing evaluation and adjustment of fluids, vasoactive medications, and supportive therapies. Continuous assessment ensures early recognition of deterioration and prevents progression to uncompensated shock. Dopamine is often chosen as a first-line agent in both distributive and cardiogenic shock because of its mixed effects. At doses of 5 to 10 micrograms per kilogram per minute, the inotropic action predominates, increasing cardiac output. When the dose rises above 10 micrograms per kilogram per minute, alpha-adrenergic stimulation leads to vasoconstriction and an increase in systemic vascular resistance. Neonates clear dopamine unpredictably, particularly if renal or hepatic function is impaired, so titration requires close bedside assessment. The maximum infusion rate typically used is 15 micrograms per kilogram per minute. While useful, some studies suggest dopamine may reduce cardiac output when vasoconstrictive effects outweigh inotropy, making careful titration essential. Epinephrine is a powerful inotrope with both beta-adrenergic and alpha-adrenergic effects. At lower infusion rates, beta-1 stimulation predominates, increasing myocardial contractility and heart rate, which raises cardiac output. At higher rates, alpha-1 effects add systemic vasoconstriction, elevating systemic vascular resistance. It is frequently selected as a second-line drug for distributive shock unresponsive to dopamine, or as a first-line choice in severe cardiogenic shock. Infusions typically begin at 0.05 micrograms per kilogram per minute and are increased in small increments, with a maximum around 1 microgram per kilogram per minute. Norepinephrine acts mainly as a vasoconstrictor. Its alpha-adrenergic effect raises systemic vascular resistance and increases arterial blood pressure, with less effect on heart rate than epinephrine. It is often used in older children and adults with septic shock, but neonatal data are more limited. Dosing usually starts at 0.05 to 0.1 micrograms per kilogram per minute, titrated upward as needed, with some reports of safe use up to 2 micrograms per kilogram per minute. In neonates with fluid refractory septic shock, norepinephrine may restore perfusion when dopamine or epinephrine are inadequate. Dobutamine is primarily a beta-1 agonist that increases myocardial contractility and improves cardiac output. Its impact on systemic blood pressure is variable. In some infants it rises, in others it falls, depending on the balance between improved output and vasodilation. Because of its strong inotropic effect, it is considered an appropriate first-line medication for cardiogenic shock. Neonatal clearance of dobutamine is variable, so response must be carefully monitored. Infusion typically begins at 5 micrograms per kilogram per minute, and can be titrated up to 20 micrograms per kilogram per minute. Milrinone is a phosphodiesterase type 3 inhibitor with dual actions. It enhances contractility by increasing intracellular calcium and produces systemic and pulmonary vasodilation. This combination makes it useful for low cardiac output states after congenital heart surgery and for infants with pulmonary hypertension. Its role in undifferentiated neonatal shock is limited and should be guided by cardiology consultation and echocardiographic evaluation. Hypotension is a common complication, and neonatal dosing data are sparse, making careful monitoring essential. Vasopressin is an endogenous antidiuretic hormone analog that increases systemic vascular resistance through V1 receptor stimulation. Unlike catecholamines, it redistributes blood flow to vital organs such as the brain, heart, and lungs. In neonates, it is primarily used as rescue therapy in septic shock that is resistant to dopamine and epinephrine. Evidence in preterm infants is limited, and risks include hyponatremia and ischemic complications from intense vasoconstriction. Because of these concerns, vasopressin is generally reserved for refractory cases and used under specialist oversight. Key clinical pearls summarize critical principles for recognition and management of pediatric shock. Hypovolemic shock is the most common type and typically responds well to careful fluid resuscitation, reflecting its preload-dependent physiology. Cardiogenic shock requires a different approach, as excessive fluids worsen ventricular congestion. Inotropes and afterload reduction support contractility and forward flow. Septic shock combines distributive, hypovolemic, and cardiogenic components. Rapid administration of antibiotics within the first hour and aggressive fluid resuscitation are central to reversing the pathophysiology. Compensated shock highlights the limitations of blood pressure as a sole marker. Normal systemic pressure does not exclude impaired perfusion or early shock. Early recognition across all shock types is critical to prevent progression to cardiovascular collapse. Management must be tailored to the underlying pathophysiology, as hypovolemic, cardiogenic, and distributive forms each require distinct interventions. Adherence to these principles improves organ perfusion, prevents irreversible injury, and optimizes outcomes in critically ill neonates. Neonatal shock occurs when tissue oxygen delivery is insufficient for metabolic demands, even if compensatory mechanisms maintain blood pressure temporarily. Hypovolemic shock is the most common type in neonates, arising from blood loss, third spacing, or inadequate intake. It responds to careful crystalloid boluses because neonatal cardiac output is highly dependent on preload. Cardiogenic shock results from primary myocardial dysfunction, such as congenital heart disease, myocarditis, or arrhythmia. Additional fluid can worsen pulmonary congestion and compromise oxygenation, so therapy focuses on inotropes and afterload reduction. Distributive shock is characterized by inappropriate vasodilation and maldistribution of flow. In neonates, sepsis is the leading cause, producing vasoplegia, capillary leak, and sometimes myocardial depression. Compensated shock emphasizes the danger of relying on blood pressure alone, which may appear normal. Early recognition of subtle signs such as tachycardia, delayed capillary refill, cool extremities, oliguria, or altered mental status is essential to prevent progression to decompensated shock. Neonatal shock assessment requires careful physical examination, laboratory evaluation, and advanced hemodynamic monitoring. Vital signs and perfusion parameters provide early indicators of compromised output. Tachycardia, cool extremities, delayed capillary refill, weak pulses, and subtle changes in alertness are often the first clinical clues. Urine output greater than 1 milliliter per kilogram per hour indicates adequate renal perfusion. Laboratory markers, including pH, lactate, base deficit, and electrolytes, quantify tissue hypoperfusion and guide interventions. Advanced monitoring with central venous pressure, arterial lines, echocardiography, and mixed venous oxygen saturation allows real-time evaluation of preload, cardiac function, and tissue oxygen delivery. Management is tailored to the type of shock. Hypovolemic shock is treated with cautious crystalloid resuscitation. Cardiogenic shock requires inotropes and afterload reduction while minimizing fluids, and septic shock combines aggressive fluids, early antibiotics, and vasoactive support. Hemodynamic targets include maintaining age-appropriate blood pressure, warm extremities, normal mental status, adequate urine output, and correction of metabolic acidosis. Recognizing compensated shock early and intervening before hypotension develops is critical in the neonate to prevent cardiovascular collapse and multi-organ injury.